Great. Very nice to meet you today, Poonam. My name is John Edwards from Dallas, Texas. And my job really at Citius Tech is to lead our management consulting team. The management consulting team is a newer division for Citius Tech where we are doing work more on the strategy side, the people change side. How do we get adoption and make sure that the technologies that we're introducing are actually being utilized to their fullest and realizing the value that's expected at our clients. I come from 30 plus years of experience working in the healthcare sector in the US, having worked predominantly with payers. In the US, of course, we have commercial payers as well as government payers, and then providers from integrated health systems out to provider practices. And so I joined Citius Tech in the last year, and I'm thrilled to be with a company that is so focused on healthcare. In fact, it's 100% of what we do. All the work that we do is healthcare, which is really refreshing for me, having worked with much larger firms that were diversified. I think it brings a quality of focus and intentionality about what we're doing that differentiates us in the marketplace. And I'm thrilled to be here.
Great. John, the conversation we're going to have today would be mainly weaved around the data and data sets. So the first question I have for you is the idea of having a perfect data set is often seen a prerequisite when you're deploying an artificial intelligence system or AI. Why is this assumption a flawed assumption, especially in the context of healthcare data integration? And what are some of the common misconceptions healthcare organizations have when it comes about end-to-end data integration?
Great question, Poonam. The reward for doing good work in data is a request for more data. I've been a data warehousing guy most of my career. I'm a statistician by training from Ohio State University. And I learned early in my career that as organizations progress in their maturity towards a data-driven organization that's using insights to drive their results, they end up becoming more and more creative and desiring more data to be gathered and more insights to be gathered. In fact, the trend we're seeing in the marketplace right now is people considering having insight as a service. So rather than having everybody have to build all the collections of data and cleanse it perfectly, being able to send that data through predefined algorithms that could create insights, because sometimes what people need for AI is an insight, not all the raw data by itself. And so a key portion of every AI project is identifying the data that's absolutely necessary to be able to obtain the results, and then identifying where can you substitute data for the data you thought was absolutely necessary because you find out some of the data isn't available. And so that act of deciding about how to substitute data in an analytic model is something that I was trained on as a statistician way back when I was in graduate school. And now we have AI that can help us with that and do it very efficiently and effectively. But for healthcare people specifically, they're so trained as clinicians to rely on data that has been created through devices that they've trusted, that have passed a certain level of rigor and nothing else. If it wasn't on their scale, on their device, they don't trust the information. And we have to get to a place where we're willing to trust information that we didn't create ourselves, if we're going to take advantage of the breadth of data that's now available for us to be able to make decisions. We have built a data quality trust framework, Poonam, that allows our clients to not only identify the data that they wanted in their AI model, but to also have data created every time the AI models work. Because unless you have transparency about how AI is working, there will be significant hesitation and resistance towards adopting something they don't understand. People don't like a black box with AI. They may not understand all the statistics. They may not understand LLMs and all these fancy AI terms. But end of the day, clinicians especially are responsible for making best decisions about the care of their patients. And they want to be able to stand behind the decisions they make with the data they used. And so our data quality trust framework creates a repeatable way for that information to be gathered that is needed to be able to increase the trust in the data that's reliable. So you asked about a mistake sometimes people make. I think a big mistake they make is believing their data has to be perfect before they can use it. There is no such thing as perfect data. Data is always incomplete. But we as humans, our whole life, learn to interpret incomplete data. As babies, we learn that. And as we grow, we learn it. We go to school and we learn how to gather additional information and make better decisions with incomplete data. We have to go through the same learning as organizations, how to understand, how to use this new tool called AI, and how to feel comfortable making decisions when we don't have perfect data.
Right. Thank you, John. I really liked your point around the presumptions we have as a human around data. So I would like to seek your expertise on how can AI models be trained or adapted to function efficiently when there are fragmented or incomplete data environments, typically when you are in an environment of legacy EMRs and siloed systems.
I think that that's a great question, Poonam, especially in the clinical setting where you do have legacy systems that don't talk to each other. EMRs have advanced so much compared to the data that used to be digitized and available, and yet it's still not complete. The information that is captured in an EMR is based upon what's needed by that institution to practice healthcare in that moment. It doesn't create a complete picture of everything we know about the person. What we could know about the person with their genetics or their other characteristics that directly influence healthcare, like their family situations, the environment that they live in, the other aspects that aren't clinical and aren't captured in the workflow of a clinical solution. And yet, as we gather more complete data and create profiles of our patients, a type of analysis that's often done is called cohort analysis, where we look for commonality amongst people. Everyone's individuals, but they might look more like a group of people. And we can learn from the group of people that have incomplete data, but across those different people, they have a more complete picture of that cohort of individuals. And with that cohort of individuals, we can use techniques to be able to substitute for missing data. It's a common technique that's part of every regression model that we've ever experienced as we learn statistics growing up. You're creating a model that allows for statistically reliable substitution for data that's missing and predicting the data that's needed. AI takes that to a whole nother level. But it also brings the possibility of the hallucinations of an incorrect substitution for incomplete data, which is why we have to have techniques to be able to keep people in the loop, to make the information transparent, and to allow for techniques that allow us to feel confident about where we can use the data. Currently, there's a lot of interest in agentic AI. And I think that the early inroads of agentic AI that we're going to see are going to be in non-clinical settings. Healthcare is going to get more comfortable having agency in their AI when it's not a clinical decision. Over time, as they become then comfortable with the techniques used to be able to allow that agency to occur, they'll start to apply it into clinical settings where they still have a person in the loop to be able to supervise the decision. And then over time, we'll get to a place where the art of the possible becomes normal, where we're using that information more reliably. But it will take time. In the past, it's been observed that to adopt the best practice in healthcare by doctors, it takes 17 to 18 years for the majority of providers to adopt a new practice. It's because they were trained how to do it in their residency, in their early practice of medicine, and they develop habits. AI is accelerating the amount of new ways of doing things that our clinicians are going to have to face. But they're human. We're going to have to give them time to be able to feel comfortable with the technology and with new ways of making decisions.
Right. John, thank you for touching upon the agentic AI part. I was about to come on that. So I would like to understand what is the precise role of agentic system that it plays in enabling AI to adopt in real time? And how do you see the shift of deterministic to agentic framework changing the AI deployment landscape, specifically in healthcare sector over the coming years, over next 3 to 5 years?
I think the exciting part of agentic AI is the possibility of learning models, models that are continually examining decisions that were made and being able to make a better recommendation the next time it comes around. In the past, Bayesian statistics tried to do this for us. It was a different approach than traditional statistics that would look for the decisions and create a new probability model based upon previous decisions. AI takes that to another level of agentic AI and learning. A client that we're working with right now is thinking about using prior authorization with some level of agentic AI. They know that there's some very simple cases that are clear-cut decisions, and yet their nurses spend 15 minutes to a half hour reviewing a case that is clearly approvable based upon the evidence that's been presented in the clinical case, the guidelines, and it's very possible to create a summary of that information and to make a great decision. And yet we're spending a clinician's time reviewing something that might be better spent reviewing a more complicated case. And so an example of where traditional rules-based approaches meets agentic AI is coming up with a predictive model of the probability of approval based upon the information that's created. A rule could create the rule that says if it's above 90% probability of approval, just approve it. Agentic AI has a person in the loop that would look at the decision and say, yes, it really was an approval. It really was an approval. Or when it wasn't an approval, learn why it wasn't and make the probabilistic model get updated the next time we run it. And so it moves it from a hard and cut rule to an ever learning rule based upon that person in the loop and the decisions that are being made on top of the AI that's applied. In the example of prior authorization, there are some cases that are so complicated that it will always require a peer-to-peer interaction, a doctor talking to a doctor, and a meeting of the minds and a decision about what's best for the patient. We shouldn't expect any time in the near future those most complicated cases to be solved by agentic AI. It's going to be still a case where we could augment the services of the provider by making them more efficient to be able to understand the case and to be able to identify the unique nuances by being able to search the records more effectively. In those complicated cases, a doctor might receive hundreds of pages of clinical records. Helping them ask questions to a chatbot and be able to identify what's in the record could still be using AI from Gen AI perspective, but not agentic AI. A doctor will still have to talk to a doctor. But if we could identify those cases that need that type of treatment and move some of the easy cases off the queue, we can still increase efficiency. We can drive cost out of the system and abrasion out of the system. The doctors requesting the service just want to care for their patient. They don't want to have to justify themselves every time they turn around. Another trend that we're seeing in the US market is a thing called gold carding, where if a doctor is always getting it correct, they always get approval for the prior authorization, we should be able to judge them as worthy of skipping to the front of the line, skipping the process. But yet you have to still, even with that, continue to monitor the quality of their work, that they're continuing to keep that level of success. So it may be another place, Poonam, where agentic AI can complement gold carding standards, because you could run some of those models and identify if we only saw the cases we saw today from the doctor after they got their gold card, would we still say they deserve the gold card? A way of doing quality control testing, similar to what's done in other kind of manufacturing facilities, where you're sampling and testing. These techniques are now going to come into their own into healthcare. where we make a science more than an art in some of our practice of healthcare, where we identify places where rules can apply and guide and help people to become more efficient and more focused on the places where art needs to dominate, where those conversations between brilliant people need to occur. But moving some of the other work off their queue.
So, in that case, what would be your recommendations for designing a AI-driven healthcare system that is resilient to data variability and integration gaps, I would say?
It's a great question, Poonam. I think there has to be data quality checks upfront as the data is entering into our process, making sure that the information meets a level of quality that allows for the agentic AI or generative AI solution to work, because the quality of the data coming in is sufficient. If we can't judge that coming in, we could make mistakes based upon thinking we understood the kinds of data we would receive from a training data set, but not testing it in operations. And so we have to test it every time for quality coming in. We also have to, as I mentioned, the data quality framework, we have to test it on the model itself. Look at its predictive value, look how it's performing, and collect metrics every time the AI runs. So not just produce a result, but produce metrics that measure the operational process and environment itself on the quality of the information and the quality of the algorithms. And then where we do have a signal of a person approving the previous decision or overriding the decision, we have to collect that as well. We have to be able to understand where a human judgment caused the model to be overruled and have that be part of our learning so that we can bring attention back to that in the retraining of the model and in the automated improving of the model that can happen with agentic AI. So it requires us to think about not just the positive use cases of what we were planning to do with an algorithm, but also this whole ecosystem of how the data behaves and works through the system. It does require a different way of architecting solutions. It requires us to have a plan of how we're going to have a framework that allows us to control the usability of these solutions. You know, it's an interesting extension of this data explosion is the devices that people wear. You know, there are so many different devices, watches or smart scales or smart cuffs that people have for blood pressure, and so much possibility of remote monitoring of health that could provide fresher signals. We only see our doctor once 2 or 3 months. We could be getting signals that are clinically relevant every day in our home. And yet that information isn't by a approved and controlled, device that is in the clinician's office. And yet the clinician needs to find a way to feel comfortable taking in this new data signal and incorporating it with appropriate levels of trust with the other things that they're using to interpret and guide the care of individuals. You know, my brother was an occupational therapist before he retired. And 25 years ago, he was monitoring congestive heart failure patients with scales as an experiment that his hospital did in Ohio. But you know what they found? People broke the scales. They didn't take care of these devices in their home. And it was expensive in order to repair the devices or train people on how to use them. Technology has come a long way, but I know my kids broke a scale the other day. People happen to technical devices in the home. You know, things happen. And we have to find a way to feel comfortable with an imperfect control over that technology, allowing for incomplete data to be gathered that is so valuable and useful. With congestive heart failure, if you gain weight overnight, you need to have a clinician check to see whether your diuretic's working to be able to prevent you from having potentially life-threatening complications because your heart's not working well. A simple check. Did you gain more than 5 pounds overnight? Because water is building up in your system can save a life. It would be inappropriate for us to reject the data because it's not on our scale. because it's not under our control. We have to find ways as clinicians or as technicians to open ourselves up to this less than perfect data so that it can be used to improve the quality of care that we provide our patients. And it's happening. It's just happening slower than I would like, but it's happening. And I think Agentic AI, with the ability to test the quality of that information and to have additional ways we look at the data, can help people increase their confidence in being able to use that data.
Right. John, while we had this conversation evolving around the entire healthcare industry, I'd like to know what what kind of an approach CitiusTech has been taken in terms of AI model validation and benchmarking when it comes to data sets which are unavailable or incomplete in any sense. And are there any analytical tools or frameworks you recommend for assessing the robustness of AI outputs derived from imperfect data?
Well, I think that one of the things that we usually talk to our clients about is the importance of adopting an AI governance model internally. Because at the end of the day, the institutions that we support are going to be accountable for the decisions they make. And so compliance needs to weigh in, IT security and data needs to weigh in, but so do clinicians need to be involved if there's clinical data being considered. And in addition to data governance that already exists at most of our clients for traditional data warehousing applications, AI governance is another layer of thinking about how are we going to decide as a company to be willing to adopt and adapt our processes to use data and to use AI in our business practices. We think that along with that AI governance, most clients need to have an AI COE, a center of excellence that has talent hired into their organization that allows them to have people that understand how to make decisions with this data and how to create these solutions. So processes that guide, people that have the right talent. The other thing that we do with our clients is we bring accelerators. We have literally now hundreds of data models and algorithms that we've created, about 400 algorithms that we've created that are based upon proven practices of how you use this data to be able to create insights. And if you can move faster into insights, it's easier then to help people understand how they can use the data. The value usually isn't in the raw data. It's in 30 different data elements combined together that point to a recommendation because of a model of how you interpret all that data together. And so having algorithms that are already available that they can implement with appropriate data quality coming in, use the data solution that's well-defined, well-documented and understood, and then understand how to interpret those models, they're able to more quickly accelerate their adoption of AI. And so we believe that over the next 5 to 10 years, we're going to see a significant democratization of AI models that will create insights as a service, that will allow you to not have to create everything yourself. Just like we offer those accelerators, others in the industry will offer accelerators. But if there's a way to be able to use utilities that create insights in a safe way, according to your data governance, using people that understand how to use these tools, we can more rapidly, obtain insights we can use to be able to move forward our patients. We usually, though, recommend to our clients prioritizing value that they aspire to achieve, but identifying some use cases that are lower risk to start with. Lower risk meaning a clinician isn't going to be hesitant about making a decision about it because they're not ready yet. Administrative use cases are sometimes a good place to start. Even IT use cases. The way we do IT work, whether it's creating a help desk ticket or configuring a server or how we do testing requirements, can have AI applied to it. And it can gain the necessary skills in our staff at our clients that they feel comfortable then tackling a more complicated business process that might have clinical results. But let's start first with maybe a billing function or a scheduling function or an IT function rather than a clinical decision. And in that way, we can gain experience and feel greater confidence and go through the adoption curve that comes with adopting with new technology. End of the day, AI, in my opinion, is a business problem and a people problem, not a technical problem. We have to get comfortable with new tools. We have to get comfortable with welcoming a new person to our team, an agentic AI employee, where we understand what they're capable of doing and don't give them work they're not capable of doing. Know how to use them appropriately within a team. When we can think of them as part of our team and know how to use them effectively, we'll be able to do amazing things. When we have uncertainty about that because we don't have experience, we're going to make mistakes. So let's make those mistakes on places where no one's life's on the line because we're making a mistake. Let's make those mistakes on use cases that are much lower risk. That's the advice that we give as we're helping people mature what they're doing in this area.
Thank you, John. Thank you so much for sharing that. While we're talking so much around AI and data, we cannot miss out on regulations. So, can you just touch upon how the regulatory environment is evolving to support AI applications, especially in the US or other major healthcare markets?
Yes. Oh, I mentioned prior authorization earlier. There's a new set of rules going in next year that's going to require electronic prior auths. So prior auths need to come across digitally. So the information's available to be able to make an efficient process and a system between a payer and a provider. But the algorithms that are used have to be transparent. It has to be understandable, not just to a clinician, but to the patient as well. Decisions that are made have to be communicated in a way that everyone can see and understand. And it's now regulatory required for any care that's being provided for a Medicare patient, which is our biggest government payer. Typically, whatever CMS does as a government payer, commercial follows suit in the US. And so there's a significant revolution around using this tool of prior authorization, making sure we're doing the right thing for the right people, but making sure that it's understandable and transparent. And with that, it should lead to greater consistency between payers. It's very frustrating for a provider that I ask for the same service to two different providers or two different payers, and I get a different answer of whether I can do it or not, because their rules are different. The way that they evaluate whether it's necessary or not are different. Healthcare shouldn't be different by who your payer is. There should be standards that we follow, and there should be data we can interpret in a consistent way. And the regulations are absolutely leaning into this. And if you're going to use AI for prior auth, the current regs will require a person to be in the loop in the decision. It will not allow for agentic AI to make the decision on their own because we're not there to that level of trust yet as a culture, as a level of maturity around this critical decision. You know, prior auth tends to be used on new technology or very expensive, complicated procedures. And the desire is to make sure that it's going to bring success versus harm and make sure people aren't being experimented on and that they're getting services that make sense. At least that's what the payer would say. The provider would say, it's just a hassle. You know, I can't treat my patient the way that I think's best. You know, I'm the one that went to medical school. I'm the one that is accountable for this patient. Let me do what I need to do. And so there's a friction. AI and data will help with that friction with this movement towards electronic prior auths. But just like there was a learning curve with meaningful use standards with EMRs, there was a proof point needed and there was reporting required to make sure that we were using these medical records for value for the patient rather than for other reasons. Prior auth is going to go through a similar situation. And I think that we'll see that occur in other types of AI utilization as well, especially when clinical decisions are being made. There'll have to be proof that there's value being created. Poonem, I hope this was helpful today. It's been great talking with you. And I hope you were able to gather what you needed for some of the articles that you're working. If you need more information from me, I'd be glad to spend some more time with you at some point in the future.
Yeah, right. I had one more last question for you, if you would. It's just an opinion that I
Super.
want to fetch from you. So, if
Hmm.
healthcare organizations could change just one assumption or approach around AI and data integration, what would you recommend? Why, what it should be, and why?
I would recommend that they consider starting small. People often have the adage consulting crawl, walk, run. Some people say I and they want to go and run the Boston Marathon and they haven't run for years. They haven't used data or AI in their culture of how they make decisions or how they do business practices. And they hear from the pundits out there that 30 to 40% cost efficiency can occur and they want it now. It's not reasonable to believe that you're going to be able to go and run the Boston Marathon if you haven't been training. You need to start small and create a reasonable plan for how you're going to mature your organization to be able to do more interesting things with AI. But even starting small, you can start to see value. You can start to get measurable results that will encourage your company to make further investments, to be able to push the envelope further. And if you do it with business at the table rather than just an AI team, a group of data scientists showing something's possible, if you get the business helping to prioritize what start small looks like, you'll gain greater enthusiasm. So start small, have business leading rather than IT or AI leading. And I think that that's the biggest fallacy that's happened over the past couple of years, Poonam, is AI has still been considered to be the area of data scientists. Data scientists are an important part of AI. The value of AI, though, is getting the business to think differently about how they operate. And the only way that's going to occur is involving them. So start small, but don't do it just with AI and IT. Involve the business, find a use case they can be excited about, they can see value from, and create the momentum necessary to really transform your organization. AI has the potential. People will get in the way. And if you don't even involve the business, they will get in the way eventually when you try to involve them because you didn't involve them early enough. So that's my biggest advice, I guess, Poonam, is, start small, but involve the business.
All right. Thank you so much. Thank you, John. Thank you for answering my questions. And thank you so much. I really appreciate your time. Thank you so much for joining.